Hello. In this talk, I will cover the writing of a pathology report, and this is something that we do routinely every day. However, there are some points that are worth taking note of. And of course, this is a subjective practice. It really differs from pathologist to pathologist, and I'm sharing with you my own practices, and hopefully you will find them useful. So we will first look at the aims of why are we actually writing the report, because this informs us on the type of information we would like to include. And then I will go through some of the major components of the report, in particular the gross description and also the blocks description, microscopy, and finally I will say a few words about the art of writing comments. So the first thing that we really want to consider is who are we writing the report for? And of course, in the first instance, we're writing this for the managing clinician or the managing clinical team. Sometimes we are also writing this for the second opinion clinician and also future clinicians down the line, whether or not the patient is coming back for a related or an unrelated condition. So for this, we must be able to convey adequacy, of course, the diagnosis, and prognostic information where relevant. So in writing for the clinician, we are answering a few questions that the clinicians will have. Firstly, is my clinical question answered? For example, is this an infective or a neoplastic process? Secondly, how certain are we of the diagnosis? Thirdly, does the clinician need to actually re-biopsy the mass or the lesion for diagnosis or for prognostication? The next audience that we are writing for is actually other pathologists, and of course this includes the multidisciplinary team pathologist or the clinical pathologic conference pathologist, the second opinion pathologist potentially, and also similarly a future pathologist in case of future visits that have relevant pathology. So we have to bear in mind that we should convey the morphological features, the relevant block numbers where necessary, because this is very helpful for a reviewing pathologist. And also it's quite useful to mention the amount of lesional tissue in small biopsies with a view for future ancillary testing. And of course, we are also writing for the patient because in some instances, the patients may actually request for the biopsy report. And not to forget, we are writing this for ourselves as well as a reflection or culmination of our training in pathology. So the main components, of course, include identification of the patient, the lab, the pathologist, the date, the specimen type, the gross and blocks as well as microscopic descriptions, the diagnosis, comments when necessary, and also a supplementary report if necessary. For example, if we are adding ancillary tests or a second opinion report. So some notes for the specimen type, of course, if this is in doubt, it's always important to check the electronic medical records for the operation notes or perhaps even speak to the procedurist where necessary. The gross description should always correspond to the specimen taken. And one example that we may sometimes miss out is, for example, in colonic biopsies, where there are polyps that are biopsied. Sometimes the scope only mentions that there's one polyp that's biopsied. However, we receive 3 tissue fragments. So instead of mentioning that we receive 3 polyps, it is more accurate to mention that we have received 3 polypoid tissue pieces, because sometimes the single polyp may actually break apart. So this mainly reflects the importance of having the gross description correspond to the actual procedure that is being done or the procedure findings. And it's also very important to ensure that the gross description and the blocks description correspond to each other. For example, if we are describing a 2 centimeter mass in the gross description, the blocks description should correspondingly refer to the 2 centimeter mass or using the same adjectives. For microscopic description, similarly, this should correspond to the descriptive terms we use in the gross description so that we can recognize the actual area that we are describing. And for comments, they are of course not always necessary, but there are times when they can help to clarify certain questions that we anticipate from the clinician. So I'm going to focus on gross, blocks, and microscopic description, as well as comments in this talk. For gross description, the main aim is to describe the lesional tissue very clearly and concisely so that whoever is reading the report can visualize it over the phone. I mean, in other words, because if there is no photographic record, the person who is reading the report will be able to see very clearly in his or her mind what the specimen looks like. It is important to be concise, accurate, and descriptive. And of course, again, the blocks must correspond to the gross description. So some things that are good to avoid would be in omitting an overview description. If you have a particular organ, for example, a thyroid with multiple nodules, it's always helpful to give a very quick orientation by mentioning there are multiple nodules in both lobes, the largest located in the right upper pole. Just a very quick description. Avoid overly long sentences and don't omit the actual size or appearance of the organ. So very often, general terms like enlarged, swollen, edematous may be omitted. The color, of course. Colors are helpful for visualization, especially if the specimen is fresh. For example, instead of just tissue fragments, you can say reddish, irregular tissue fragments, or give colors such as tan, brownish, whitish, etc. Avoid using different terms for block as well as gross description. For example, if you describe a nodule as yellowish in the gross description, don't then use pale for the block's description. And try to also avoid using first, second, or third tissue piece because naturally when we receive tissue pieces, there is no order to them. Instead, you can use more descriptive, specific terms such as largest tissue piece or 2 centimeter or rounded tissue piece, etc. And some good habits. As mentioned, for multiple lesions, it is helpful to give a very quick orientating sentence for the overall description. Do describe by site and size, and again be consistent in gross and block description. When giving measurements, it is helpful to give the largest dimension first and also to provide the orientation, for example, 3.3 centimeters superior, inferior, etc. Harmonize with the specimen. Again, as I mentioned earlier, if there is only one polyp received, then change the gross description to 3 polypoid tissue pieces rather than 3 polyps, because this may give rise to confusion to the clinician who is reading the report. So what to describe? For the organ, it is helpful to give a general adjective, for example, enlarged, swollen, atrophic, where relevant, and the general shape as well, if this is altered and classical. And another example would be in adenomyosis, we tend to get a globular-shaped uterus. So if this is present, it is a helpful descriptive term. And of course, we have to describe the nature of pathology. For example, in mucosa or skin-covered specimens, things like ulcers, erosions, invaginations, and for solid organs, whether this is a mass, a nodule, a cavity, and so on and so forth. For discrete lesions, we describe the shape, the interface with the rest of the organ. Is it well circumscribed? Is it ill-defined, etc.? The color, and also the texture. And here are some useful terms in gross description. So this is not really within the scope of this talk, but here are some of the terms that we may end up using, and I will briefly direct you to a resource in which we have described this a little bit in more detail. So types of masses, sometimes it's just a localized area of discoloration, etc. And here is one of the resources that you may look up online. So this is PathWeb. You can just Google PathWeb and look at the Virtual Pathology Museum. There is a chapter on approach to gross pathology, how to describe that part, which also corresponds to description of gross pathology specimens. And here is just a sample of one of the pages showing you the different colors. Here is another page showing the descriptions of various discrete lesions that you may see as well. Now let's have a quick word on cystic lesions. So it is helpful to mention whether they are intact, previously opened, to mention the locularity. For example, here we have a unilocular cyst. This is actually a very typical example of an epidermal cyst with the skin, and we can see a cyst in the underlying dermis and the subcutis. So there are also other terms like paucilocular, where there are few locules, and multilocular. We should also describe the contents of the locules. In this instance, there is this grayish pulpy material. And of course, there's fluid, thickness, transparency, color. For example, clear mucoid fluid, serosanguinous fluid, etc. And we can also describe the cyst wall or the septa of the locules and mention if there are, of course, fleshy or papillary areas. Where there are multiple lesions, it is helpful to define each lesion by an easily recognizable feature, and this is often location, for example, breast, upper outer quadrant, mass, size, of course, and appearance in terms of the outline, as I mentioned earlier, as well as the color. So in this instance, there are many rounded nodules in both lobes of the thyroid, whereas in this instance, this is also a thyroid gland. We can see an irregular whitish or pale tan mass. Here is an example of a gross description of a thyroidectomy specimen where there are multiple nodules. So you can see that we can describe the nodules separately in each lobe, but it is especially helpful if we just give a very quick orientation. As an overall description, there are multiple nodules, and we can also mention that the largest is located in the right lower pole. This is very helpful to someone who is reading this without actually having seen the specimen. For this same description, I have now included the block description, and just wondering if there are any comments on this. So this is quite useful because we have the exact location. However, when it comes to this A3 to 5, it says right lobe yellowish nodule. However, if you try to correlate this with the gross description, you don't really see any corresponding yellowish nodule being described. So this, in effect, is referring to the 3 centimeter nodule. And if we mention this, it is a lot clearer where we have taken the sample from. And similarly, for A9, it's also helpful to mention the specific nodule. So when I read this gross description, I am particularly interested in this nodule because I'm concerned about papillary microcarcinoma. Hence, it is very important to make it extremely clear where you have sampled it. It is also acceptable to numerically list the different nodules, and sometimes you can write this in your blog's description. This is actually clear as well. However, personally, I prefer that the blog description directly mentions the location and the size of the nodule because it is a one-step reference rather than having to read this and then refer back to the text to look for the nodule in question. Why not just describe exactly where the block was taken from up front? Now, when we have ill-defined lesions, for example, in post-neoadjuvant chemotherapy breast resections, it's sometimes difficult to know where the actual residual lesion starts and ends. So mapping sections are taken, and often in these instances, we have serial slices of breast parenchyma which are numbered. It is very important to mention the direction of slicing as well as the direction of composite block sampling. So for example, the direction of slicing, the lesional area is serially sliced and the slices numbered 1 to 5 from lateral to medial. And as I mentioned, if composite blocks are taken, If we just see this A6 to 8 is slice 2 contiguous sections, we don't really know which direction the blocks are taken from. Are they taken in this direction? In which case, a better description would be A6 to 8, slice 2 contiguous sections from anterior to posterior. Or are they taken in this direction? In which case they should be described as contiguous sections from superior to inferior. And you can see how this just addition of this direction is immensely helpful in a person who has not seen the specimen to actually appreciate how the blocks are sampled. So in summary, for gross description, describe as much as you can. The color, the shape, the cut surface, locularity of cysts. Describe multiple lesions very clearly, identifying them by site and size. State an overview first, if possible. And I cannot overstress the importance of blocks corresponding to the gross description. For composite blocks, it is very helpful to give the direction anterior to posterior, superior to inferior, etc., in order for the person who is reporting the microscopy to visualize the sampling a lot more easily. Now I'm going to move on to microscopy. And for the microscopic description, again, it is important to be as systematic as you can. Apply the templates where applicable, and I'm sure many departments will have templates that they use, particularly for tumor resections. So for the main lesion or tumor, we can, of course, describe the low power features in terms of growth pattern, architecture, for example, tubules, glands, nests, islands, cords, etc., and then move on to high power, focusing on nuclear and cytoplasmic features, and of course, prognostic features in terms of the histotype, the grade, whether there is necrosis, lymphovascular, invasion, margins, etc. And it is also important to take note of important negatives. And this really depends on the specimen type and the clinical history. So in writing out important negatives, we are actually answering the clinical question as to why they are doing this biopsy. For example, is this tumor or is this infection? And it's also important to include, of course, any other pathology or background findings, particularly in cytopathology. And also just a very quick description of the non-lesional tissue for completeness. If a comparison has been made with the previous biopsy, it is also important to record this. So be considerate in the microscopic description. Do state the relevant block numbers for focal pathology. For example, if there is lymphovascular invasion, you can actually just put the block number in parentheses. This is helpful for future review of the case. And as far as possible, to facilitate future testing, for example, for predictive tests of response to tumor therapy, if there is a small specimen, such as a small biopsy or a cell block, it is helpful to mention the volume of tumor, just a very concise term, for example, sparse tumor cells or abundant tumor tissue. So here are just some pictures showing you low power architectural features for microscopic description. For example, here we can see nests, and here we can see cords of cells, and here there are these trabecular arrangements. On high magnification, we then focus on the cytomorphology, which I will not go through here. And for background, and this is particularly relevant in cytology, you can mention whether we see benign cells, whether we see necrosis, mucoid material such as seen here, and this is often extremely important in the diagnostic evaluation. And coming to important negatives, again, this stems from knowing the clinical concerns, for example, to exclude TB or to exclude a fungal infection, if this is particularly highlighted by the clinicians, we have to mention, even if we don't see evidence of this. So it is important to also tailor this to specimen type. For example, for lymph node biopsies, I personally do make it a point to mention whether I see necrosis, granulomas, or epithelial cells. and, for example, in colon ulcer, to mention whether we see viral cytopathic changes, granulomas, or parasites, because these are all relevant to the clinical scenario. In terms of the diagnosis, of course, give the outright diagnosis where possible if it is an obvious, definitive case, and just be aware of the terms used in different levels of certainty. So it is difficult to really prescriptively assign percentages of likelihood for these different terms, and I have tried to do this from just informal personal survey of individual consultants, and we can see that for my own subjective level of certainty for these terms, it does differ from the group of polled consultants. And you can see that in some groups, raise the possibility of really can vary quite a lot. So this is just something to be aware of when you are using these terms in your report. The main point is that when you are certain, give the diagnosis outright rather than saying things like suggestive or suspicious of. Now, coming to the last part, which is the art of comments. When are comments helpful? When we are noting previous relevant history, for example, a lung mass where the patient has a history of colonic carcinoma. When we have reviewed other relevant pathology slides, for example, previous slides from a primary tumor. When we are conveying uncertainty in terms of sample adequacy, and also in terms of our diagnosis. It is very important to convey this in your report. And on occasion, if you feel that it's necessary, I think it's also helpful to call the clinician and discuss the case with them to let them know our uncertainty. It is also important to note differential diagnosis in our comments, should there be any, and of course also to suggest further relevant management. How strongly we suggest them can also vary because of course we do not know the specific clinical situation or the patient's scenario. So sometimes if there is wiggle room, we can write things like consider or may be helpful if clinically indicated, so as not to back the clinician into a corner. And we can also ask them to correlate with relevant clinical or imaging findings. If we feel very strongly that a certain course of management is required, then we can just say outright that we recommend this. For example, if there is a salivary gland tumor that is of uncertain malignant potential, we can recommend excision. And of course, we can also include the second opinion consultation results in our comments. And if you want to name a specific pathologist, it is important to ask permission from the pathologist beforehand, before writing his or her name in your report. So here are some examples on comments. For example, for adequacy, if this is a parotid swelling and this is an FNA, we only see benign salivary gland parenchyma. Of course, the main issue is this a non-diagnostic aspirate, which it would be if the sample was taken from a discrete nodule. Or the other differential diagnosis is if this is a diffuse swelling, and particularly if it's bilateral, we may be looking at sialadenosis. So a comment can be given to reflect this. Only benign salivary gland parenchyma is seen. In the context of a discrete lesion, this sample is not representative. However, in the appropriate clinical context, the findings may represent sialadenosis. This, of course, comment is a lot longer if we do not know the clinical scenario. An example of comments on differential diagnosis: malignant cell seen, consistent with high-grade urothelial carcinoma. If the scope findings suggest the possibility of CIS, we may want to also convey this in our comments, that we cannot actually differentiate between carcinoma in situ and invasive carcinoma on cytology. And here is one of the more straightforward writing of comments for suggesting management. For example, in a cervical lymph node FNA, where there are highly atypical lymphoid cells, we can then recommend excision biopsy. So the take-home messages would be, when we are writing a histology report, to bear in mind that we have to write a concise and an accurate report. We have to answer the clinician's question at hand to the best of our ability. And for the gross description, we should be descriptive as much as possible because there is often no other record of the gross appearance other than what we have written. We have to describe the nature of the lesion, the color, texture, shape, and be as systematic as possible. The block's description should always match the gross description. And for microscopy, be systematic, low power, high power, background, relevant negatives. And of course, for comments, these can be used in the scenarios that I've listed, such as to convey concerns or uncertainty, to make recommendations, and to take note of comparisons with previous histology. And I also want to just leave you with this note that every pathologist has a different style. And while you are in your training, especially for senior residents, it's very helpful if you can actually take the best points from each different consultant and then develop your own style. And of course, this is something that will evolve over time. Thank you.